everybody, and good afternoon or good evening in Indonesia. I open this academic session in which Mrs. Endang Lestari is going to defend her thesis, Interprofessional Education's Lessons from Indonesia. I welcome, of course, the candidate and wish her lots of luck. I also welcome the supervisors, Professor Scherpie and Dr. Stalmeyer, of course, the members of the opposition, whom you will meet a little bit later on, and also family and friends who are watching this academic session online. But before we start the opposition, I give the floor to the candidate to give us a sort of introduction on her work presented in the thesis. The floor is yours, Mrs. Candidate.
Thank you very much. I would like to share my presentation.
This is the wrong view.
Yeah. Dear Prorector, members of the Corona, dear family, colleagues, friends, and the audience, thank you very much for giving me opportunity
to present. You have the wrong view. You have presenter view. Switch the screens.
Oh. Excuse me. Is that okay now? No?
Screen share at the
Sorry.
moment.
Endang, are you working with two screens?
Yes.
Yeah, that's the problem. So you have to switch which screen you're presenting from.
Okay. Excuse me.
Yeah, and Endang.
Yeah, excuse me. So, is that okay now?
That's okay.
Yes, excellent. Breathe and go ahead.
Yeah. Thank you very much. I'm really sorry for the problem. Dear Prorector, members of the Corona, dear family, colleagues, friends, and the audience, thank you very much for giving me opportunity to present the result that I get from my thesis entitled Interprofessional Education Lessons from Indonesia. My name is Endang Lestari. I work at Universitas Islam Sultan Agung, Semarang, Indonesia. And for the next 15 minutes, I will give an overview of my research that I performed during my PhD. We learned that health problems are getting complex all over the world. And in our country, Indonesia, the challenges of health services are even more severe since our country has to deal with health problems of very large and diverse populations of around 269 million people. And the area spans within 13,000 islands, and it with different races, ethnicity, religion, social strata, education, community, language, and cultures. Hospitals and public health centers face health problems of such complexity in our country. And in that situation, they require the skills and knowledge of healthcare professional team that can work together in promotive, preventive, curative, and rehabilitative services to improve healthcare outcomes. Interprofessional collaborative practice is very demanded in that situation. And interprofessional healthcare collaboration happens when multiple health workers from different professional backgrounds work together with patients, families, carers, and communities to deliver the highest quality of care across settings. There are 8 elements of interprofessional collaborative practice. Those are responsibility, mutual trust, accountability, coordination, and etc. Unfortunately, poor interprofessional collaboration by the healthcare professional team is still in evidence, and it poses significant threat to patient safety in the form of adverse outcomes, longer hospital stays, and even medical errors. To prepare better collaborative skills of healthcare professionals, it has been suggested that students of health professional education have to be trained in interprofessional education program. Interprofessional education, or IPE, is an educational program that occurs when students from 2 or more professions learn about, from, and with each other. And when we want to develop an IPE program which is suitable for Indonesian context, we need to pay attention on the very strong culture of social hierarchy within Indonesian healthcare setting. And we should also consider both the stakeholder perceptions, such as the perceptions of lecturers, university leaders, and also the perceptions of students. And we should also consider about social and cultural aspects. And by considering those, we need to design an appropriate education format for interprofessional education. And by considering those, the main aim of this PhD dissertation is to investigate and understand the aspect that should be considered when implementing interprofessional education in an Indonesian or Asian context. And this aim was translated into the following research question. The first, what are students and teachers' perception of and readiness for interprofessional education in Indonesia? And the second, to what extent can BBL be considered an education format that is suitable for interprofessional education in Indonesia, and to what extent is PBL effective as an education format for interprofessional education? And the last, to what extent can a community-based education program be considered a suitable education format for interprofessional education in Indonesia, and to what extent is community-based education effective as an education format for interprofessional education? Generally speaking, we have 2 types of study. One was evaluating students and teachers' perception and attitude toward IPC and IPE, which was reported in chapter 2 and chapter 3. Both of these studies were mixed method studies. Data were collected from some health profession education institutions around Central Java using questionnaire and focus group discussions. And the participants were students and teachers from midwifery, nursing, medical, dentist, and dentistry program around these schools. The other studies were evaluating PBL and community-based education as education format for interprofessional education. Chapter 4 and Chapter 5 utilized mixed method study. Data were gathered from groups of students from midwifery, nursing, and medical programs who learned together in interprofessional PBL and interprofessional community-based education. Meanwhile, Chapter 6 was quantitative study and data were gathered from discussion section within community-based education of nursing and medical students. From the analysis of questionnaire and focus group discussion, we learned that students were generally favorable to IBE. However, analysis of focus group data revealed that early exposure to clinical practice in hospital or public health center triggered negative perception of IBE. Students who experienced low quality of collaboration among healthcare teams during their exposure to clinical practice in hospital or in public health center, they tend to be pessimistic with IBE. Nevertheless, in general, we may say that SN contact are ready to implement IBE. Hopefully that by implementing IBE, health profession students in Asia can reap its benefit. Faculty members mostly had positive attitude toward IBC and IBE. They agree that IBE has potential to remedy interprofessional collaboration problem. Teachers suggested that curriculum, scheduling, additional skills for teacher and logistics things should be considered before implementing IBE. And they also suggested that IBE could be embedded within the learning activities of existing modules. And they also suggested that students should be equipped with their professional knowledge and skills before they're taking part in IBE. Within the interprofessional problem-based learning, we learned that group members from different professions complemented one another in solving learning issues. They learned from each other professions. They did correction of misunderstanding without causing offense. However, the role of tutors, social cultural norms affected students' perceptions. And asking questions is not always self-evident as well during the interprofessional problem-based learning. And the students still persisted within their professional barrier. For evaluating the implementation of community-based education for IBE, medical, nursing, and midwifery students should take part in 1 week classroom training. Then they had to be involved in community engagement where they had to do some activities such as surveys, discussion, conducting intervention program, evaluation, and reflection. And these are the pictures of their activities during the interprofessional community-based education. The findings during the community-based interprofessional education indicated that 3 weeks of IBE activities were successful in stimulating student skills in collaborative practice. However, lack of confidence and initiative of nursing and midwifery students was still reported. Moreover, the findings revealed that medical students were mostly the leaders of community-based practice. It was also reported that the role of supervisors and teachers required to be improved through faculty development program. The discussion session of community-based interprofessional learning stimulate equal participation, equal contributions, and also mutual respect among learners from different health professional backgrounds. The finding reported that students were ready for IBE. However, we learned that lack of confidence was still reported. Therefore, to better prepare students for IBE and collaborations, uniprofessional education should equip students with respective professional knowledge and skills, professional identity, and pride of own professions. And those knowledge and skills were required to enable them to participate actively within interprofessional education as well as interprofessional collaboration. We still found that early exposure to clinical practice triggered negative attitude toward interprofessional education as students experience problem of collaboration within healthcare too. In general, attitude of teachers of health professional education toward IPE was mostly positive. And teachers in IPE should be properly prepared for their role through faculty development program prior to and during the implementation of IPE. The studies reported that PBL and community-based education can be effective education format for IPE, since both education formats are interactive with small group learning, which consists of 4 to 10 students each group. Both PBL and community-based education allow and value diversity of perspective to solve a common group problem. Both formats enable students to synthesize our perspective from different personal background. And the most important thing is that both education formats include reflection. However, both formats have not been able to provide a non-threatening environment for students to learn. This could be recognized from the inconvenience of students to criticize the opinion of others. And this situation is actually partly because of students' perception toward cultural, socio-cultural norm. Hierarchical culture that is formed and developed in society and in healthcare team is likely to affect the learning process and outcomes of IPE. However, it would be wrong to assume that an IPE program cannot be executed across cultural contexts. Therefore, careful consideration must be given to cultural and contextual factors before and during the implementation and application of IPE. The last but not least, in a world where healthcare complexity is ever increasing, we need healthcare professionals to collaborate interprofessionally, and interprofessional education is warranted to prepare healthcare profession with better skills of collaboration. And this dissertation contributes to how IPE could be implemented within Asian context and within different cultural contexts. I think IPE can be implemented well by giving attention to ensure students, lecturers, university leaders have a positive attitude and better understanding toward interprofessional collaboration and education. We should also equip tutors, teachers of interprofessional education with skills to facilitate IPE activities, which can be done through faculty development program. And we should also design education format and learning schedule that fits with the context. Besides that, we should also ensure the healthcare team to in hospital as well as in public health center to perform good role model of collaborations so that the students can learn from them. That's all my presentation. Thank you very much for your attention.
Thank you very much for your interesting presentation. We have now a little bit more than 40 minutes left for discussion, and we start the opposition with Professor De Nooijer, who was also the chair of the assessment committee, and she's a professor in interprofessional teaching and learning at the University of Maastricht. Professor De Nooijer.
Thank you, Pro-Rector. Dear candidate, I would like to start with my compliments for you and your supervisory team with the innovative education you designed and implemented in Indonesia, and the way you described that in your dissertation. All chapters have been published yet, and that's very congratulations with that.
Thank you.
By using mixed method studies, you clearly show the impact of interprofessional education in the Indonesian context, in which power dynamics, as you said, plays a prominent role. So power is often under-addressed in interprofessional design and research, and therefore I appreciate your work even more. But before we continue with the questions, I would like you to explain a little bit more about these power relations in Indonesia and how deeply that is embedded in your culture. Could you explain that, what that means for healthcare?
Yeah. Thank you very much, Ale, esteemed opponent, for the question. It's very interesting question, I think. Well, power dynamic is interesting topic to discuss in interprofessional education, particularly in our culture, because you know that we have hierarchical social culture in our society, and you know that it is always influenced. The hierarchy is always influenced by age, and then by social status, and then by education, and then also by blood related, something like that. And regarding healthcare profession, doctors usually put on the highest position in our culture because of their contribution to the community, and then because of the education. So doctors usually put on the very high on the very highest level, and this situation influence how other healthcare professions interact with doctor. And in that situations, doctors usually put on the highest level in terms of deciding everything. Although when they work together in a team, then the decision usually made by the decision is usually made by the doctor, and the other professions only follow what the doctor suggested. That's what happened in our culture. And other health professions usually think that this is what they have to do. So and these situations also influence their participation during making a decision in healthcare teams. So it is not good, because students learn from that, and yeah, they think that IPE, before they do IPE, I did a need assessments to the students, and because they learned that situations in healthcare practice, how the healthcare professionals interact, which is influenced by the social norm. Mm-hmm. And they think that IPE is not important. IPE will not work. They said that because when we go to the hospital, we cannot stand in equal. We cannot stand in equal. Everything is decided by the doctor, and we just, other health profession other than doctor, they said that we just follow what the doctor say. We don't have opportunity to express our idea during decision making. Mm-hmm. That's what happened in our society, in our healthcare setting.
That already addresses my first question. Thank you for your elaboration on this, by the way. You recommend to do a needs assessment, and you did also. And what kind of information about power and social hierarchy has been derived from this needs assessment? And what implications does that have for the design of your interprofessional education?
Yeah, thank you very much for the question. Well, we got information from the students that the power relations in healthcare setting, when they do their clinical practice in healthcare setting, and then they learn that the power relation is like that, meaning that the other health profession is usually on the second position, and the first position is the highest position is the doctor. Mm-hmm. We learned that, and then when we do need assessment, as I mentioned before, that the students said that, well, it's not going to work. Although we learned this, and then we will be equal during in the training. during in the IPE training, yes, we can be equal. That's it. But it cannot be implemented within the in the hospital or in the public health center. That's what makes them pessimistic with IPE. By considering that, and then we try to. I found that from the need assessment, right? And then after that, we consider about how to make them equal, in equal position, and that's why we choose PBL and community-based education, where in community-based education the students can have opportunity to discuss everything. So the decision maker should be considered by all of the patients, not only by the doctor. Although in real in our research, I found that all of the leaders of the community-based education, interprofessional community-based education are medical students. We are actually very disappointed with that, because actually we want other professions also have opportunity to practice to become leader, but unfortunately still medical students become the leader. So that's why we choose PBL and community-based education, where they can decide everything together.
Yeah. Can I still ask a quick question, Prorector?
Yeah, short question, short answer.
Okay, so what can we learn from your studies when we want to design and implement this interprofessional education, given the power relationships in other countries?
First of all, of course, we have to encourage healthcare profession in hospital and public health center to perform good collaborations, so that they can become a role model for the students. Well, although it might be difficult and need times to come to that point, but we need to do something for that. So good role model for the students, I think. And we should also provide students that you have your own knowledge, you have your own skills. Every profession has knowledge, every profession has skills. So you should communicate that. You should involve, you should participate during the decision making. We should teach students for that.
Thank you very much.
Yeah.
I'll give the microphone back.
Okay, thank you very much, Professor De Nooijen, for your questions. Now we come to the second opponent, who's also a member of the assessment committee, and that's Professor Scherpje de Haan. She's professor in general practice in the University of Groningen, and thank you for coming all the way from Groningen, albeit online, because the University of Maastricht is always very glad to have guests from outside. The floor is yours.
Thank you very much, Prorector. Dear candidate, it was a great pleasure for me to read your thesis. You've performed many interesting and original studies in the field of IPE in Indonesia. So thank you for that. And also my compliments to your PhD team for accomplishing this huge work. Based on chapter 2, in which you have studied students' readiness for interprofessional education in students in medicine, nursing, midwifery, and dentistry, I would like to ask you some questions. Because I have to admit that I'm struggling with the scale you use, the readiness for interprofessional learning scale, the ripples, we say shortly. Because why should you be ready for learning interprofessional collaboration? If we think this is important, we never take a readiness for learning anatomy scale, for example. And also there is some debate ongoing, maybe you know, whether the ripples is of any added value, because we're already a few years later than when you've performed your research, of course. And for example, in Norway, they found that there is a ceiling effect in this scale. The students score rather high on the scale. So I wonder, What is your advice for other countries when they would like to start with IPE? Do you think the ripples is of added value, or do you think we can skip it?
Yeah, I think it is still important. At least we applying or evaluating their readiness is still important, because by implementing that, by evaluating their readiness, then I know that they are in that level of their understanding about interprofessional collaboration and interprofessional education. And based on that, and then I did a kind of I can arrange a kind of activities for students to improve their understanding about collaborations and about healthcare, the importance of collaborations within healthcare professionals, and we then bring them to the importance of IPE. So I think that's still important.
Sorry to interrupt you. But you've also performed focus groups, of course.
Yes.
And with very interesting results. And what do you think? Would focus groups only be enough?
Is focus group will be enough without ripples? Is that the?
That's my question.
Okay, yeah. When I did focus group discussion, actually, I also based on the result of ripples. So I've because in that study on the quantitative study, I found that there are still some students who have negative perceptions toward interprofessional collaboration and interprofessional education. So I think ripple is still important to be done, because by doing that, by implementing that, we know that there are still some students who need to be improved in terms of their understanding of collaborations and interprofessional education. So I think still,
thank you for your view. You still want to continue with the ripples. Okay. So then I would like to go to chapter 4, in which you made videos of interprofessional problem-based learning sessions. And the tutors scored the constructive collaborative activities with the Maastricht peer activity rating scale.
Yeah.
And I wonder, knowing all these power issues you were telling about in the position of doctors and medical students, I wondered, these tutors, were they blind to the background of the students, or did they know whether they were doctors or nurses, for example?
No, the tutors are blind because there are only tutors did the scoring. Only 2 tutors did the scoring, and they are blind. They do not know whether this participant is from medical or this participant or from nursing. Although probably from the video, I think midwifery students are wearing I mean the
coats, maybe.
Coats.
Yeah.
And probably they can think about that, but I'm not quite sure. But it's actually blind. It's supposed to be blind. Yeah.
Okay, I couldn't read that in your paper. And do you agree with me that that is an important thing to realize that they do not know which professions these people have?
Yeah, of course.
Yeah, that was a short answer. Okay.
Yeah.
I think it's time, Prorector. Do you think so?
There is time for a short question, short answer.
So yeah, short answer. Okay. Well, then I would go to your discussion, and you say, I could not study, and I understand that, the long-term effect of the program on students' teamwork, and no, not at all at patients' outcomes, I think. But how would you suggest to study that in the future? And very shortly, so only say the methods maybe you would like to use.
Probably I will invite them to do focus group discussion, or probably I will do interview with them, some of the students only, and then how do they conduct the interprofessional collaboration in the hospital and public health center. Probably that.
Okay, so
and
then in a later
yeah,
stage, I would like to discuss with you whether this self-reported behavior is enough
yes.
for us. But thank you very much for your answers.
Okay.
Thank you very much for your position, Professor Scherbier de Haan. Now we come to the following opponent, who is also a member of the assessment committee, and that's Professor Fluit. She's Professor of Innovative and Person-Centered Learning and working in healthcare in the Radboud University in Nijmegen, the Netherlands. And thank you, Professor Fluit, for coming all the way from Nijmegen. The floor is yours.
Thank you, Prorector. And dear candidate, first of all, I really would like to congratulate you with this wonderful thesis. And also, I congratulate your supervising team. Your thesis is a very interesting and very relevant, and with the aim of improving collaboration in healthcare by interprofessional education in Indonesia. And that is quite a challenge. As you mentioned already, there's a very strong hierarchy and power dynamics. And if interprofessional collaboration is going to succeed, you have to do something about power dynamics and that strong hierarchy. I would like to start a discussion with you focusing on chapter 2 and 3. In chapter 2, you have measured the readiness of students to learn interprofessional collaboration by IPE. And in chapter 3, you have looked at the attitude of the teachers towards interprofessional collaboration and education. And you found in chapter 2 that the medical students were the most positive, demonstrated the most positive attitude towards interprofessional education, and they were really ready for it. And in chapter 3, you found that the nurses had the most positive attitude towards interprofessional collaboration and education, and the doctors were lying behind. It's very interesting to see their responses on the questions concerning education, interprofessional education. They don't have real trust in it. So I was puzzled by this difference. So the medical students are positive, but the teachers or the doctors have lost this trust, or what is happening in between? What is your thoughts about this?
Dear highly esteemed opponent, thank you very much for the question. It is very interesting question, I think. Yes, that was the result. And in chapter 2, I found that medical students were the most positive, had positive attitude toward interprofessional education and interprofessional collaboration. I explained that in the chapter that the problem is that they have they need this kind of, they think that they need this kind of activity, or they need this kind of program, because they think that they can learn interprofessional collaboration, and then they can improve communication and also leadership skill and others. That's what they say. And beside that, they never, the students that I took their, the students that fill out the reports at that time was medical students, and they never got an opportunity to do clinical practice before. So they never experienced the negative or the low quality of interprofessional collaboration within healthcare team in hospital and in public health center. So they still have positive things that, well, this is very important, and this is very important for me, and we need that to improve the quality of taking care of patients, and and the outcomes of taking care of patient will be better if we do collaboration. They still have a positive thing, but it will be different from nursing students because they already have their clinical practice and they experience the low quality of collaboration within healthcare team in hospital and in healthcare center, public health center. Then they have negative perceptions toward the IPE.
Yeah, so experiencing,
yes,
so
experience
in
really,
healthcare, yeah. But how is that changed in the professions? Because the nurses are more, so what is happening there?
Yeah, when with the doctors and the nurse, I also mentioned in my chapter that the nurse really need the collaboration. They feel that, well, hopefully, when the students have IPE, the situation of collaboration in hospital will be changed. They have that kind of thing. So that they really stress that we have to do this. We have to do interprofessional collaboration. We have to collaborate well because during the real collaboration in hospital, we are usually on the second position. So hopefully when doctors and then the clinicians, they got the interprofessional education, they will change their attitude toward the collaboration. So that's why they really hope that IPE will be implemented in healthcare training.
But the real problem is in the healthcare and how the workplace learning and practice-based learning is very important to have a change in that.
Yes,
so I agree on that. Following this, I was thinking, and your presentation brought me also to this question. You mentioned that the Asian context is ready for IPE, and you have looked for the attitudes of students and teachers towards IPE and IPC. But you haven't included patients in your studies. So, and I think, and we know from research that patients can have a very strong incentive for change and behavior and learning of professionals. So what would happen if you took the patient's view in your research?
Well, that's a very good suggestion. I think I need to think about that because I haven't considered that before, taking the perception of the patients. Well, that should be done, I think. Yeah, I haven't got any idea that I should take their perception as well. But however, in community-based education, actually, we also have the perception of the community regarding their collaboration, the students' collaboration, but not with the patient, but with the community. I also took the information from them. How do they do the collaborations from the community, but not to the patient? I'm really sorry because I haven't got any information related to that. But that's good to do. Probably for the next study, I will.
Maybe for the follow-up, you haven't finished your career, hopefully.
Yeah,
so because of the important work you're doing.
Yeah, thank you very much for the idea.
Yes, okay. I'm looking at there's still some time, or yes?
I think it's time to go to the other two opponents.
Thank you.
Thank you very much for your opposition, Professor Fluit. Now we come to the following opponent, who's also a member of the assessment committee, and it's Dr. van Bokhoven. She's working at the Department of Family Medicine in the University of Maastricht. Dr. van Bokhoven.
Dear Mrs. Candidate, I also want to congratulate you with your nice thesis. And I would like to include your supervisors in this. You formed a long distance team, though not very interprofessional. I think the distance is challenging enough, but you succeeded, and that's nice to see. I appreciated that you validated your measurement instruments for your Asian setting, because in this way you did not only add to the scientific global knowledge, but you also provided the region with instruments that can be used for further research. And that's very good, I think. But that's not what I would like to discuss with you now. We have been talking about power differences a lot so far, but what strikes me is that the students from different disciplines generally are positive about the interprofessional collaboration. However, they blame each other that it does not work well. And they have prejudices about each other. So they externalize actually instead of self-reflect. My first question is, do you agree with me that self-reflection is a prerequisite for good interprofessional collaboration, and thus the topic should have been tackled in your course?
Yeah, dear esteemed opponent, thank you very much for the question. It is very good question. Yes, I think it is very important, of course. Reflection is very important, of course, and that's why we choose PBL and community-based education. And within that setting, the setting of PBL, usually at the end of the discussion, discussion on the step 7, we use 7 steps of PBL, and on the step 7, which is the end of the meeting, we did a kind of reflection. And the reflection is not only about how each student performed during the discussion, but we also discuss about how this group collaborate. So the reflection comes also, the topic, what we discussed during the reflection is also related to how this group collaborate to solve the problems that they give within the scenario. And also in community-based education, the design that we did in community-based education is that 1 week training, classroom training, and then after 2 weeks implementation in the community. So the students engage themselves. We immerse the students within the community. And in the end of the community-based education, we also performed reflections. And these reflections, the topic of the reflections usually about the program that they implement, and then also related to the collaboration of the group. That's usually what we did. So I do agree with you that reflection is the most important thing here. That's why in my presentation I mentioned that why we choose PBL and community-based education, because one of the important things there within the design is reflection. I do agree with you.
So you say we already have it in the program, which is good, I think, but still the students externalize when you interview them afterwards. So it probably does not work perfectly right now. So do you have any suggestions how you could improve this reflections so that they could more reflect on their own roles instead of the roles of the others?
Yeah. That might be the problem, because sometimes the reflections focus quite a lot of within the topic of collaborations. So probably their own role within the groups need to be evaluated as well, I think, within the reflections. Yes, that's a good point, I think.
If it's someone else's problem, you are powerless to improve, I guess. Well, you also state that, and you said in your presentation as well, that the supervisors are important as role models in this regard, which I agree with you. And they say they feel a need to improve their skills.
Yeah.
But it was not quite clear to me which skills exactly they would like to improve. Could you reflect on that? What would you like to teach them, especially also with regard to dealing with the cultural barriers?
Yeah, thank you very much. Based on that study, I think the most important things to be discussed within the faculty development program is improving the students, the teachers' understanding about collaborations. And then, you know that because it is new skills for teacher. Teaching in collaborative situations, I mean, the group is not only from medical, but also from nursing and from midwifery, for instance. And so it is quite new for them. Therefore, they need new skills. So they not only consider that, well, normally they only face one professions only. But now they have to face students, a group of students with different professions. So it needs new skills. Of course, becoming a facilitator of that kind of group is different with when they face students of in uniprofessional education. So a skill of facilitating of interprofessional group, and then skills of reflection, giving reflections. And at that time, we only stress on the collaboration. But now I got an idea from you that the students should also be, what is that? Forced. We should encourage students to evaluate their own role within the group. And that's the things that we should discuss during the faculty development program. So facilitating interprofessional group, and then giving reflection, and then understanding about the importance of interprofessional collaboration. That's usually what we talk during the faculty development program.
Okay, thank you. Do I have need for one more question?
If it's a very short question, a very short answer.
Okay. Who do you think can supervise the group best? Would it be the different disciplines, because that's the shows the equality of all supervisors, or given that interprofessional collaboration is not self-evident right now? Should you need the current highest in hierarchy, the doctors, to supervise, to emphasize the importance of the topic?
I think doctors, maybe. Doctors, I think, because hopefully that they can learn something from that as well. Besides, yeah, hopefully doctors, I think.
Okay, thank you for your answer.
Thank you, Dr. van Bokhoven, for your position. Now we come to the following opponent, who's also a member of the assessment committee. That's Professor Wesseling. He's Professor of Pulmonology, in particular the management of chronic obstructive lung diseases in the University of Maastricht and the Maastricht University Medical Center. And he has also accepted today the role of secretary, for which I'm very grateful. Professor Wesseling.
Thank you, Mr. Prorector. Can you understand me?
Yes.
Okay, good. I too would like to congratulate you and your team for a very robust piece of research and a very well-written thesis, but also for answering just about every question that I had prepared before the start of this ceremony. However, I do have some questions left, and the first question relates to chapter 4. One of the conclusions you draw from that study described in chapter 4 is that students scored highest on constructive and collaborative activities. And my question is whether that is a result of the entry level of the students before the start of the studies, or whether that is a specific element or component of the curriculum that they have compared to, for instance, the curriculum of the nurses or the other healthcare professions.
Excuse me, could you repeat again the question?
Okay, the fact that the medical students are best at the collaborative and constructive activities, is that explained by the entry level, or is it explained by the curriculum?
Oh, thank you very much for the questions, Ali Estimakonen. I think medical students have higher score of constructive and collaborative activities here because both, I think, both the entry level as well as the curriculum, because you know that the entry exam for medical students is quite difficult, and yeah, I think both of these things influence this result.
And what is it in their curriculum that specifically prepares them for these constructive and collaborative activities, again, compared to the curricula of the other professions?
In our context, I mean, in our universities, medical students have PBL, and starting from the first semester up to the end of the clinical year, pre-clinical year, and then during the clinical year, they have clinical tutorial as well. And with that, they are prepared and they are accustomed with this kind of activity. But for the other program, they have PBL only for specific topic. So this is not the regular activity for midwifery as well as nursing. Although they have PBL, but it is not their specific activity. It's quite different from medical. So probably these things also influence why do they have better constructive and collaborative activities.
Okay, thank you. That's clear. The other question, and for that I return, as a clinician, I return to the patient. You already mentioned that the patient has not had a large role in designing or executing the education, but you have lessons from Indonesia. So I thought you might have lessons for us as well. How can you involve the patient, not only in the education, but also in assessing the skills, for instance, in terms of collaboration in clinical practice? Have you thought of that?
Yeah, of course, it's one of our considerations. Actually, we are preparing interprofessional education for our clinical year nowadays. Nowadays, we are working with that. And one of the considerations is that we want to influence patients for the assessment. For daily activity, I mean, for uniprofessional education in clinical practice, in clinical year, we also involve patients for the assessments. And we want to apply this as well for our curriculum of interprofessional education in clinical year. So we are struggling for that now. And I do agree with you that we should involve patients. We need to know their perceptions toward the collaboration of doctors, nurses, and other health professions when they do or when they give healthcare to the patient, or healthcare services to the patient.
It's a good point. Do you think, are you considering introducing a format or a specific form for the participation of the patients in that, or is it more or less an informal type of feedback that you ask? Can you think of a format or a specific structured routine to use?
In uniprofessional education, we use observation checklist. We ask the patients to give observation checklist to the students' performance. And I think we will also do the same things for the interprofessional education in clinical rotations. So probably we will do that. So far for feedback, I think we do that with simulated patients. We haven't asked the real patients to give feedback to the students, but for the simulated patient, yes, we asked them to give feedback to their collaboration, to the students' collaborations in interprofessional educations. But in uniprofessional education, we also do the same thing. We ask the simulated patients to give feedback to that.
Okay.
Thank you very much.
Thank you, Professor Wesseling, for your position. Ms. Lestari, the time appointed for the defense of your thesis has passed after ora est of the beadle, and the degree committee will now withdraw to another online room to discuss the quality of your thesis and of your defense. And I ask you and your company to await the results of our deliberations, and then we come back in this online room. I therefore suspend the meeting. Mrs. Candidate, Ms. Lestari, I reopen the session. The degree committee here present online has assessed the quality of your manuscript and your defense. In view of its positive verdict and taking into account your previous qualifications, the degree committee has decided to grant you the degree of doctor. Professor Scherbier is authorized to confer upon you this academic distinction in accordance with Dutch university custom. I invite your supervisor to now take the floor.
Thank you very much, Prorector. First, a question. Do you promise Endang to work in accordance with the principles of scientific integrity at all times, to be careful and honest, transparent, independent, and responsible?
I promise.
By the authority vested in us by law and in conformity with the decision of the committee here present online, I hereby confer upon you, Endang Lestari, the degree of doctor and grant you all rights attached by custom and law. As evidence of this, you will soon receive the degree certificate signed by the rector, the secretary, the supervisor, affixed with the official seal of the university, as shown by the medal. Yes. Thank you. And now René Stahlmeier will give the laudatio.
Dear Endang, I am so very happy that I'm one of the first to congratulate you on receiving your PhD in medical education. And of course, Albert congratulates you very much as well. We have gotten to know you on this journey as being hardworking, kind, and someone who starts to laugh her big smiling laugh when she is uncertain or stressed. You were tenacious and showed perseverance, and have grown into a wonderful scholar and advocate for interprofessional education. And perseverance is a word that characterizes you through and through, dear Endang. We first met in the fall of 2011, as you were one of the first participants of our new Writing a PhD proposal course. And it was immediately clear that you were on a mission, successfully implement IPE at your university in Indonesia. Not an easy job. You had experience with educational change, as you were previously involved in implementing problem-based learning in this setting. Not easy, because speaking up and being critical in a group setting is not really an Indonesian value. Yeah. And therefore, you knew that implementing IPE in that same setting would be very hard. But you wholeheartedly believed in the importance of IPE, and so you persevered and set off onto your PhD journey. The data collection for the first two studies seemed to be done in no time whatsoever. But writing it up did not come as easy to you as the data collection did. But again, you persevered. And slowly but surely, the studies started to crystallize. In the meantime, you had found a passion for public speaking, and you were presenting all over the world your results at various conferences, even resulting in prizes for your posters and presentations. You spent time in Maastricht, a total of 90 days to be exact, as this is required by the Indonesian government for acknowledgement of your PhD. And in that process, you made many friends with the Indonesian students here and Indonesian families that took you in during your stay. Together as a team on your PhD journey, we learned several important lessons. Not only did we learn about implementation of IPE in Indonesia, but we also learned about working in an intercultural PhD theme. When your PhD buddy, Makoto, defended his thesis in 2019, I already commemorated the incident of the Dutch professor getting tea for his Indonesian and Japanese PhD students. Both you and Makoto were completely at a loss. The professor was getting you students tea. This was so wrong, but we learned to overcome these kind of differences. However, more importantly, you taught me a very big lesson about feedback in an intercultural PhD team. A couple of years back, there was a time when you had seemingly dropped off of the radar, so to say. Albert and I couldn't get in touch. And it took a while before we found out what had happened. Just before that time, we had a meeting to discuss what you should do to analyze the data for chapter 4. And I had made a suggestion on how to proceed. However, it turned out that even though the idea sounded great in my head, it wasn't possible to execute the analysis as such. But you, instead of coming back to me to say, well, René, I tried, but it doesn't seem to work, you kept trying and trying and trying some more because you didn't want to say to one of your supervisors that their feedback had not been helpful. That made a very big impression on me. And since then, I always tell PhD students that I supervise to not keep trying endlessly and tell me when they cannot work with my feedback. So thank you, Endang, for that lesson. Endang, it has been an eventful decade. While working on your PhD, your career catapulted to a higher level, and your bosses gave you bigger and more responsibilities, which kept you busy, very busy. And besides that busy work life, your personal life has not been easy. I have come to learn over the years how prone Central Java is to natural disasters, calling you away to do relief work. But moreover, you have known a lot of very personal losses over the year, most recently due to COVID-19. Albert and I saw your emotion and the struggle, but we also saw that you felt an extraordinary need to continue on with life, to keep working, to finish your PhD. And that is what you have accomplished today, dear Endang. You persevered, you kept going, and now we can welcome you as a PhD into our academic midst. I'm sorry that the circumstances do not allow us to do this defense in person in Maastricht, but I trust, inshallah, that we will meet again in the future, safely hug and celebrate your accomplishments. And for now, I wish you a very happy and safe celebration in Indonesia with your loved ones and colleagues. Dear Endang, till we meet again.
Thank you, Dr. Staalmeijer, for a great laudation. And dear Dr. Lestari, also on behalf of the Board of Deans, I congratulate you with the honor you have acquired. I hope that you can celebrate it in the right way, and I wish you a great follow-up of your career. I also congratulate your family and friends, of course, and your supervisors, Dr. Staalmeijer and Professor Scherbier. I thank the members of the assessment committee for their presence and their work, and also the Luc Peters and the Padel for their work to make this online academic session possible. And having said that all, I herewith close this academic session.